fast as possible. The question is this: when the patients come to you, when the patients come to dermatologists, they obviously do not want their surgery, but when they come to plastic surgeons, maybe they want. So what it is in their mind, what they want to have. They want to keep themselves as themselves, or they want to be totally different. They want to keep themselves. Of course, if such a patient comes to you, there's not too much to do. Like, you have to do a normal rhinoplasty with such a patient. But there are many patients who are like her, who don't want to have surgery, who have less drastic problems. So what to do with those patients? To be able to answer that question, I want to give you a few numbers from my clinic. Back in 2005, when a patient came to us, we were just doing rhinoplasty. Now, a normal rhinoplasty patient is going to be only 1/3 of the ones who come to us, because I do many other things. That all started when we started using these double-sided needles. This is a simple key wire, sharp on both ends, and there's a hole in the middle. And we can use these sharp needles in both directions, and let's see how we're going to make a use out of them. Now, after starting using those needles and telling the patients we can do no suspensions, suddenly we had this huge group of patients who wanted to have minimally invasive results. So that's a valid question, whether we really need to do all these different steps of rhinoplasty in every patient. Well, probably not, but the answer is, when you are looking at the patient's nose, we have to check two things. One of them is the dorsum. If it's too high, then, like playing with that, with minimally invasive approaches would not be very satisfying. And the second is the tip. If it's white, you have to do something with it. Now, if the dorsum is really high and white, like in this patient, there is, again, nothing to do. We have to do a normal rhinoplasty to really fulfill the patient's wishes. But there are many patients like these who are whiter. In these patients, we can do a tip plasty, which means you just open the tip of the nose under local anesthesia or sedation. Make the cartilages thinner, maybe rust the bone a little bit on the head and on the lateral sides, and take a piece of the upper cartilage, which is again very simple, and then go out. Now, these are the results. What you can get is less invasive. We are still ways to go. This is something less than surgery, but still invasive. But you can really get nice results without giving the patient any general anesthesia, without having any stent whatsoever. The lateral view, again, she actually needs a normal rhinoplasty, but playing with the tip cartilages, you can really have a smooth improvement of the nose in general, and this takes 20-25 minutes. That's it. And the lateral view. Now, if the patient's nose is long, this is one of the hardest cases for a dermatologist, because what you usually do is to fill the gaps. But if it's long, you have to make it shorter. How to do that? How to do it shorter? But you can use this nose suspension technique in the office in less than 15 minutes under local anesthesia. That's what I'm going to talk more about. So what you do, you just do the local anesthesia to the whole nose. You make a lateral incision on the lateral side, like we call it transfixion incision. And with the scissors, you just elevate the whole skin. This is very necessary because what you want to do is to lift the skin, pull it up, and wait till it gets stuck in the new position. So here is a very short video simulation what we are doing. After local anesthesia, with our double-sided needle, this is a simple 3O protein. You take a bite through the periosteum, then subcutaneously go back, take a bite through both domes, and then going all the way back, suspending the tip to the periosteum at the base. Like this. And this is the result what you can get with only a suspension. Now, when I sent this paper to our journal, they said, come on, we have done something else with that. And by chance, I had the video of this particular patient. Look at the video. You see, what happens is the rotation of the tip is masking the height of the dorsal. So even if you just shorten the tip, you are going to balance the dorsal height. So this is the surgical video of what we do. Again, I will keep it very fast. This is the transfixion incision. The patient is under local anesthesia. Actually, she's a plastic surgeon herself. So we do the nasal skin elevation. This is a very safe plane, nothing to be afraid of. Then we separate the feet of the medial crurae. This cartilage I have to take out because when you rotate, the cartilages will hit each other. So what I do, I take this part of the cartilage up so that I create enough space for the rotation of the tip upwards. It's again very simple. You just turn the nose inwards and make a fusiform full cut incision, taking the mucosa as well as the cartilage together, which is going to actually also refine the tip width and the bulbousness. And then you just put one simple suture. Then we do this hole or puncture on the lateral side of the nose. Initially, we are taking a deep bite through the periosteum. This is a normal proline, just the needle cut off and put into our double-sided needle. Now, subcutaneously, I go all the way down. And here, the trick is you shall keep the tip of the needle inside the skin when you are turning. And then going all the way back, you are taking one single bite through both domes, make them thinner, and then finally rotate them upwards, all the way up. So, or two presentations. So then what you do is, you just rotate them upwards. And let's come to the results. This is such a patient, the result after 1 year, which means it's totally stable already. Now the trick with these patients is you have to overcorrect, because in the first 3 weeks the sliding will pull the tip a bit downwards. So if you finish the operation at the exactly nice position, you're going to have a bit of fall. So you overcorrect till the skin gets attached. It takes like around 3 weeks, but what you get after a month is forever. Another case again, one year post-operative, the oblique and the lateral views. Again, this is a combination of the midfacial, neck, and tip suspension. About the other parts of the suspension we will talk in the afternoon. What is important is to have a proper patient selection. If the nose is long, you can use this technique, but if there is something missing, then you have to do something else. In those patients, you have to do fillers, which is going to be discussed by Raj.
You know,